Most people assume that when a surgeon tells you an operation is necessary, that settles it. The doctor has the expertise, the facility has the tools, the consent form is waiting. Just put your signature on it. I used to think the same way, until I started paying attention. Paying attention to the patients who entered those operating rooms for what seemed like standard procedures and came out fundamentally different. Not improved, different. A man who checked in with a painful back and checked out unable to take a single step. A woman who made it through open heart surgery but lost half a year of her life to complications nobody had prepared her for. Here's what the medical world rarely tells you. The older your body gets, the harder it has to fight just to endure an operation, not the illness itself, the surgery. My name is Dr. Eric Sanat. I'm a cardiothoracic surgeon with more than 20 years of experience inside operating rooms. And today, I'm going to give you an honest account of 5 surgeries that carry serious, underreported risks for anyone over the age of 60. Let me pose a question. If you take a brand new vehicle and one with 200,000 miles on the odometer and run them both through the exact same stress test, do you expect identical results? Of course not. And yet for years, medicine applied the same surgical standards to a 70-year-old body as it did to a 40-year-old one. Same protocols, same recovery benchmarks, same timelines. That's beginning to shift, but nowhere near quickly enough. Here's what actually happens inside an aging body when it goes under general anesthesia. The heart strains to keep up. The lungs take far longer to clear the anesthetic agents. The kidneys slow down in processing medications. And then there's the brain, and this is the part that genuinely catches people off guard. The brain can become temporarily disoriented in ways that persist for weeks, sometimes months. There's a clinical term for it, postoperative cognitive dysfunction. In patients over 70, it occurs far more frequently than the medical community openly acknowledges. Now, I want to be entirely clear on one thing. Age by itself is not a reason to decline surgery. I've operated on 85-year-olds who recovered faster than some patients in their early 50s. Age is just a number. But frailty is something else entirely. Frailty is a clinical designation. It means the body's reserves have fallen below a critical threshold. Roughly 40% of people over 75 show measurable signs of frailty. That figure climbs to nearly 60% past the age of 85. So the real question is never simply whether someone can survive the procedure. It's whether they can endure the recovery. Those are two entirely different things, and that distinction is going to matter enormously right now. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass grafting, CABG, is one of the most commonly performed major surgeries in older adults. The concept is straightforward. Your arteries are blocked, so we redirect the blood flow. For the right candidate, the results can be extraordinary. But what the brochures never show you is this. Open heart surgery requires stopping your heart entirely. We place you on a bypass machine, a device that temporarily takes over the functions of both your heart and lungs while we work. For a fit 62-year-old, that's a manageable stress. For a 79-year-old carrying kidney disease, mild diabetes, and early cognitive decline, that bypass machine represents a simultaneous assault on every major organ system in the body. Research shows that in frail elderly patients, open heart surgery carries a 30 to 40% risk of serious complications. Stroke, kidney failure, prolonged confusion, extended ventilator dependence. And here is the figure that tends to stop people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days following this procedure. So what's the alternative? In many cases today, one exists. It's called TAVI, transcatheter aortic valve implantation. A catheter-based intervention that requires neither stopping the heart nor opening the chest. Less dramatic than traditional surgery, but far gentler on a body that needs compassion, not combat. Does this mean you should flatly refuse cardiac surgery? Absolutely not. It means you should walk into that consultation and ask one direct question. Am I a candidate for a less invasive approach? That single question can change the entire trajectory of your care. Surgery number 2. Aggressive spinal surgery. Back pain in your 60s and 70s is practically universal. I cannot think of a single patient over 70 who hasn't brought it up. And the solution that gets offered with increasing frequency is spinal surgery. Fusions, multi-level decompressions, hardware running up and down the vertebral column. Let me be clear. Some spinal surgeries are absolutely essential. When the spinal cord is actively being compressed, when bladder control is being lost, when paralysis is a real and immediate threat, surgical intervention is urgent and justified. But elective spinal fusion for chronic back pain in older patients? The evidence is genuinely concerning. A major study published in the journal Spine found that in patients over 65, complex spinal fusion carried a complication rate exceeding 40%. And the most common complications weren't trivial: blood clots, infections, hardware failure, and a condition called adjacent segment disease, where the vertebrae immediately above and below the fusion begin deteriorating because the mechanics of the entire spine have been permanently altered. One section is locked in place and everything else absorbs the consequences. And what frustrates me most is this: when it comes to pain relief, studies consistently show that for many elderly patients with degenerative spinal disease, aggressive surgery provides no better long-term outcome than a well-structured program of physical therapy and targeted injections. No better, but with dramatically greater risk. A colleague of mine, an outstanding spine surgeon, once said to me, "Eric, sometimes the best operation is the one that never happens." I've carried that thought with me ever since. Have you ever been told surgery was your only option for back pain? Drop that in the comments. I want to know how many of you have heard those exact words. Surgery number 3, major cancer resections. This one is the most difficult to address because when someone receives a cancer diagnosis, the reaction is immediate and visceral. Remove it, eliminate it, do something. I understand that instinct completely. I would feel it too. But 2 decades in surgical medicine have taught me something essential. The purpose of treatment is not simply to excise a tumor. The purpose is to give that patient more quality years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient achieves the opposite. A concrete example: pancreatic cancer surgery, the Whipple procedure, is among the most technically demanding operations in all of medicine. We remove the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. The operation itself runs 6 to 10 hours. In younger, otherwise healthy patients, it can be genuinely life-saving. But in an 80-year-old with cardiovascular disease and compromised kidney function, the procedure may be technically successful. The tumor is removed, and the patient still dies within weeks. Not from the cancer, from the surgery itself. This is known as futile surgery, and it is far more prevalent than anyone in the medical community wants to acknowledge openly. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what's called failure to rescue. A complication arose that the weakened body simply lacked the reserve to overcome. So what conversation is worth having? Ask your oncologist this directly. If we choose not to operate, what would watchful waiting, radiation, or targeted therapy realistically look like for someone at my age and in my current health condition? That question opens a door many patients never realize exists, and what's behind it is sometimes genuinely the better path. Surgery number 4, elective joint replacement in seriously ill patients. Hip and knee replacements rank among the most successful surgical interventions ever developed. I say that without qualification. For the right patient, a new joint is genuinely transformative. People go from barely shuffling across a room to keeping up with their grandchildren. It's remarkable medicine. But here is where it becomes complicated for older adults. The word elective means the procedure is scheduled, not urgent. You have time to reflect, time to prepare, and crucially, time to assess whether this is the right moment for your specific body. Because here's what the data shows. In patients over 75 carrying 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries a meaningfully elevated risk of perioperative complications. Blood clots are the greatest threat. Deep vein thrombosis, clots forming in the legs, can migrate to the lungs and become a life-threatening pulmonary embolism. In elderly patients with already reduced circulation, this risk is substantially higher than in younger individuals. Add postoperative pneumonia from prolonged immobility. Add hospital-acquired infections. The picture grows significantly more complex. I want to be precise here because I have no interest in frightening anyone away from a surgery that might genuinely improve their life. The question isn't whether to ever consider a joint replacement. The question is my body in the strongest possible condition right now? Optimizing blood pressure, blood sugar, body weight, and cardiovascular health before elective surgery can dramatically reduce complication rates. Some hospitals now require a formal prehabilitation program before they'll schedule these operations for high-risk elderly patients, and that approach is exactly right. Has your doctor ever discussed prehabilitation with you ahead of a planned procedure? Most people have never heard that word. They absolutely should. Surgery number 5, emergency abdominal surgery. I need to pause here because this one is different from everything else on this list. You don't schedule emergency surgery, it finds you. A perforated bowel, a ruptured appendix, internal hemorrhaging. These situations don't pause for calm office discussions. But here's precisely why it belongs on this list. Understanding the risks before an emergency strikes changes how families navigate those terrifying, high-pressure moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates anywhere in surgical medicine. We're looking at 30 to 50% in the most severe cases. Not because the surgeons are inadequate, but because an elderly body under sudden acute trauma is fighting on every front simultaneously. The liver, kidneys, heart, and lungs all sustain impact at once, and the inflammatory response that a younger body reins in within days can spiral in an older body into systemic inflammatory response syndrome, a cascading shutdown of multiple organ systems in sequence. It is as serious as it sounds. So what can you actually do with this information? 2 concrete things. First, don't ignore abdominal symptoms. Persistent pain, bloating, or meaningful changes in bowel habits in anyone over 60 warrant prompt medical evaluation. Catching problems early means managing them before they escalate into true emergencies. That single habit can change everything. Second, have this conversation with your family now, not in a hospital corridor at midnight. Now. What are your wishes if emergency surgery becomes the only option? What does quality of life mean to you? These are not morbid conversations. They are among the most loving things you can offer the people who may one day be standing in that corridor. All right, we've walked through 5 surgeries. Now let's talk about what you actually do with this knowledge. Because information without action is nothing more than anxiety, and that is the last outcome I want for you. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should have ready. Write these down. Question 1. What happens if I don't have this surgery? A skilled, honest surgeon will give you a straight answer. If the answer is that nothing critical changes in the next 6 to 12 months, you have time. Time to reflect, time to seek another opinion, time to prepare your body. Question 2. Is there a less invasive option? Medicine has advanced enormously in the past 15 years. Robotic surgery, endoscopic techniques, catheter-based procedures, options that didn't exist a decade ago are now accessible in most major medical centers. Question 3. What does recovery realistically look like for someone at my age and with my health profile? Not the average patient, you, your heart, your kidneys, your current medications, your home situation. The answer should be specific, not boilerplate. Question 4. And this is the one most patients never think to ask. What is your personal complication rate for this procedure in patients over 70? Surgeons keep track of this. They know their numbers. A confident, transparent surgeon will tell you without hesitation. If they seem uncomfortable with the question, that discomfort itself is meaningful information. Before I get to the most important point today, I want to offer you something genuinely hopeful, because this is not a video about fear. It's about options. And those options have never been more powerful. Minimally invasive surgery has fundamentally changed what's achievable for elderly patients. Laparoscopic procedures with small incisions and camera guidance dramatically shorten recovery times. Robotic-assisted surgery enables a level of precision that unassisted human hands simply cannot match. And catheter-based cardiac interventions have made treatment accessible for patients who never could have tolerated traditional open surgery. And beyond surgery itself, something I wish far more patients were told, optimized medical management is genuinely powerful. The right combination of medications, structured physical therapy, targeted injections, and nutritional support can manage many conditions that once seemed to demand a surgical solution. The body wants to heal. Sometimes our role as surgeons is simply to step back and give it what it needs to do exactly that. I want to tell you about one of my patients. I'll call him Gerald. 71 years old, retired engineer, sharp as they come. He came to me after 3 separate surgeons had each recommended open heart surgery for a blocked coronary artery. 3 surgeons, 3 consultations, the same recommendation every time. Gerald wasn't frightened of the surgery itself. He was frightened of losing who he was. He'd watched his wife undergo a major operation 2 years earlier and emerge from it confused, depleted, and never quite herself again. He looked at me and said, "Dr. Sanat, she went in as my wife and came out as someone I had to take care of." That sentence has never left me. When I reviewed Gerald's complete profile, his kidney function, his frailty score, his cognitive baseline, I sat with him for 40 minutes, not 15, 40, and I told him the truth. Surgery was a valid option, but so was an intensive medication protocol paired with cardiac rehabilitation. For his specific profile, the published data showed comparable 5-year outcomes between the 2 paths. He chose the non-surgical route. That was 4 years ago. Last month, he sent me a photograph. He's standing at the summit of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he'd just won everything. Here is what I need you to carry with you. This is the single most important thing I'll say today. A surgical recommendation is not a verdict. It is the opening of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own health. The moment you sit across from a surgeon, you have every right to ask the difficult questions, to push for every alternative, and to take every day you need to make a clear-headed decision. The surgeon holds the scalpel, but you hold the choice. And that choice, made with complete information and full clarity, is the most powerful instrument in medicine, more powerful than any operation I have ever performed. Let's bring it together. 5 surgeries that carry serious hidden risks for people over 60. Open heart surgery in frail patients, where less invasive alternatives increasingly exist. Aggressive spinal fusion, where the evidence for pain relief is far weaker than most patients are led to believe. Major cancer resections, where the true goal must always be more good years of life, not just tumor removal. Elective joint replacement in seriously ill patients, where timing and preparation matter as much as the surgery itself. And emergency abdominal surgery, where the best protection is early detection and honest family conversations before crisis arrives. None of this means avoid surgery at all costs. Surgery saves lives every single day. I have witnessed it. I have been part of it. I am proud of it. The message is simpler than that. Be an informed patient. Ask the hard questions. Explore every alternative. Seek a second opinion, and if necessary, a third. Your age is not a liability. What is the one question you would most want to ask your surgeon before a major operation? Tell me in the comments. I read every single one. And if this video helped you or someone you love think more clearly about a surgical decision, share it. That one action might be the most valuable thing you do today. Take care of yourselves, stay curious, keep advocating for your own health. You deserve a surgeon who takes the time to explain everything, and a medical team that sees you as a partner, not a case file. And one final note. Everything shared here is general medical information grounded in published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, have a full, honest, unhurried conversation with your own physician or specialist. They know your history, they know your body, and that conversation, direct, informed, and never rushed, is precisely where good medicine begins.